Hello, everyone. The Center for the Women of New York presents Breakthroughs in Breast Cancer Treatments. Hosted by Victoria Pilati, that's me, Cecilia Venosta-Weigel, and Malini Shah. And we proudly present our guest speakers, Dr. Seeta Trivedi and Argie Moutafis-Agelarakis. Since our founding in October of 1987, the Center for the Women of New York has shown that women working together can be an effective force. We are a voluntary nonprofit organization dependent on dues from our members and on the volunteer efforts of business, professional, and community women and men in New York City. At the center, we believe education is the cornerstone of women's economic independence. We advocate strongly for women's full equality by partnering with like-minded organizations and elected officials. Whether we're marching for worthy causes, celebrating women's accomplishments in leadership, the arts, or sports, camaraderie is a hallmark of CWNY. We've come a long way since the second wave of the women's movement in the latter half of the 20th century. And while there are many struggles ahead, we celebrate how far we've come.
Hello, everyone. I'm Cecilia, as Victoria said. We just quickly wanted to share what we do. For those of you who don't know the center, our current services are caregiver phone support group for those who take care of elderly people in our families or friends. We have conversational English as a second language. It's a legal support team that's via email. If you have any questions about legal issues, we're here to guide you in the right direction. We do referrals to different services like shelters and services for women in need. We are doing webinars on women's issues such as this one. We also have individual counseling for women in crisis, as well as support groups for women in crisis. Our upcoming events are a book club. We're looking for someone who run it. So if you're interested, please let us know. Career workshops, computer classes, financial literacy series starting in January. And we will have an exhibit of women artists and their work. We are also planning on bringing back our walking group. Our upcoming webinar is the Power of Financial Independence. That will take place on November 10th via Zoom at 6:30 p.m. So we hope if you're interested, you can join us. This topic is really relevant right now because everyone's like worried about preparing for that rainy day. So join us and please feel free to share if you know anyone who would be interested, if not you. Welcome. As Victoria said, we depend on the help of our supporters. So Victoria, go ahead.
Yes, so if you'd like to donate to help us continue these programs, you have our link here at CWNY.org, donations. If you'd like to become a member, that is another way to support us. Please join us at CWN.org membership. Or volunteer with us. We have plenty of openings with our volunteer positions. You can download this PowerPoint presentation at CWNY.org past events sometime tomorrow. So your questions are very important. Please, and they will be addressed after each presenter has completed their presentations. So use the chat box at the bottom of your Zoom screen to ask any questions and they will be answered. If you dialed in, email your questions to events@cwny.org. So with us today is Dr. Seeta Trivedi, a board-certified physician in internal medicine and medical oncology. And her passion is treating cancer patients and the challenges they face and instilling hope for a better and longer life. So, and we look forward to hearing from her in a few moments. So in this webinar, Dr. Trivedi will be answering these questions. What exactly is breast cancer? What are the various types of breast cancer? What are the stages? We always hear about stage 1, stage 2. What does that all mean? And what are the treatment options? And our survivor story from Argie Moutafis-Agelarakis, in her story, she will share her journey from diagnosis to post-surgery. Welcome, Dr. Trivedi.
Thank you so much, Victoria, Cecilia, Malini, and Center for Women of New York for having me here today to talk about breakthroughs in breast cancer treatment. Cecilia, thank you for helping me go through the slides. If you could advance them for me, please. Thank you. Next, please. So I am a medical oncologist, community oncologist who loves the field of oncology specifically because it enables me to help people through tough times and tough transitions in their life. As a woman, breast cancer is something that all of us need to always be cognizant about and think about, and there is no better time than October, which is Breast Cancer Awareness Month, to present this and have this webinar where we can talk more about how advances in breast cancer treatment could impact us and could impact people in the years going forward. We wear pink in support of all cancer survivors and all cancer fighters. Next, please. So how huge is breast cancer in the United States? As we all know, it's pretty big. In our lifetime, 1 out of 8 women will wind up being diagnosed with breast cancer. And so that could be somebody who is your neighbor, your friend, your sister, your mom. It's all of us, and including us as physicians. This is something that we always need to be aware about and need to understand what we can do in order to prevent and in order to treat. As per the American Cancer Society, you can see some figures on the slides over here. In 2018, more than 40,000 women unfortunately died from breast cancer. In 2020, it is estimated that nearly 42,690 breast cancer deaths will occur. These are both men and women. There's a smaller segment of population in our male counterparts who are also diagnosed with breast cancer, and treatments for cancer care apply to both males and females. Even though we are getting better at cancer treatment, unfortunately, cancers are being diagnosed in younger women. And so in order to continue to fight this good fight, we need to make sure we are getting new treatment options out there for our patients. Next slide. So what is breast cancer? And I'm going to address a couple of the common terminology questions that patients have. So breast cancer is cancer literally that originates in the breast tissue. The breast tissue is a complex tissue that consists of lobules, or these are glands where milk is formed. And that milk eventually drains out through tubes or ducts that eventually bring it in the front to the nipple and out of the breast. Cancer can happen when changes occur in these glands or in the ducts. And what winds up happening is that normal and healthy cancer cells sometimes get damaged, which is normal wear and tear, the body has a mechanism of repairing these cells. Occasionally that mechanism of repair gets defective, gets mutated, and so these cells continue to change or mutate into tumors. And once they grow, they're hard for the body to control and they get bigger. And eventually they can have the ability to spread. That is what we call metastases, when the cancer spreads to the different organs, to the different parts of the body. Breast cancer commonly goes to the associated lymph nodes, which are in our axilla or our armpit, in our chest, often to the bones, the lungs, and the liver. Also can spread to the brain as well. Another common misunderstanding is that cancer that winds up spreading to the bone, it is thought of often as, now I have bone cancer. Unfortunately, it's not that. It's still breast cancer, but it is now affecting your bone organs. So metastatic cancer is the same as stage 4 cancer. If it does wind up happening in the organs such as the liver or the lungs or the bone or the brain, it is still breast cancer. It is just cancer that has spread to those organs. Next, please. So there are other types of breast cancers as well, depending on what our structural architecture we can see underneath the microscope. We talked about cancers from the ducts and the lobules, ductal cancer and lobular cancer. The two of these two combined pretty much takes up more than 90% of all breast cancers. Other rare types of breast cancers include medullary carcinoma, papillary carcinoma, tubular carcinoma, metaplastic carcinoma, and Paget's disease, which is cancer of the nipple. Mucinous cancer and inflammatory breast cancer oftentimes relates to the involvement of the breast with this more aggressive type of cancer, and needs to be treated in slightly different ways than a routine cancer. Next slide. So let's talk a little bit about staging of breast cancer, because that is a very common question when you need to sit down with your oncologist or understand what is being told to you. Breast cancer, just like all other cancers, is classified into 4 stages, 1 through 4. Stage 1 is early cancer. Stage 4, like we talked about, is metastatic cancer, or cancer that has spread outside the breast to the other organs. We divide each stage of cancer into sub-stages in order to help us understand, again, the extent, the prognosis, and the treatment options a bit better. Stage 1 cancer is cancer that is commonly less than 2 centimeters in size, and we divide this into cancers that are less than a centimeter, and then 1 to 2 centimeters. But these cancers do not involve the lymph nodes in the armpit. Stage 2 breast cancers could include cancers that are slightly bigger. These can be up to 5 centimeters in size, and they may involve the lymph nodes of the armpit or the axilla. And depending upon how many lymph nodes are involved, they could be late stage 2 cancers, or if you have more lymph nodes involved, this could make it a stage 3 breast cancer. Similarly, if you have a larger than 5 centimeter tumor, this could be considered a stage 3 breast cancer as well. For a stage 4 breast cancer, size does not matter. It could be a small or a large tumor, but if it is in an organ outside the breast and outside the lymph nodes, it is stage 4 disease. Next, please. So let's talk a little bit about breast cancer that can be cured. These are cancers stage 1 through 3, and we will go through different stages and different subtypes of cancer to understand what the different or what the new breakthroughs are. Next, please. So let's talk about something that we call stage 0 breast cancer. Stage 1 through 3 breast cancer, and even though stage 1 is considered early stage breast cancer, there's also something that we call stage 0 disease, which is what we call in situ breast cancer. In situ means in development. So the cancer cells were caught super early, where they had started to form, but they had not yet started to invade. These cancers are cured when the tumor lump that on biopsy shows in situ cancers are diagnosed and removed. However, because these cancers do not spread by definition because they have not invaded surrounding structures, the question is, how much do we have to do for them? Traditionally, treatment includes surgery to remove your lump, radiation, followed by the possibility of hormone therapy. This is standard of care because if this is not done, then 20 to 30% of these lesions will progress to what we call invasive cancer, and then they do have the potential to spread. So there is currently a study going on that is called the Duchess trial that is using something called the Oncotype DX DCIS test to give us a numerical value that tells us what a woman's individual risk is for her DCIS to be aggressive or not aggressive. Knowing this answer will help us possibly eliminate something like radiation that can cause side effects such as skin burns, irritation, low blood counts, and fatigue. Hopefully, in the next 2 years, we will have the answer to this question. Currently, Oncotype DX DCIS test can be ordered by your radiation oncologist, but is not considered standard of care because we still do not have all the information that we need. This is a big trial that will help us answer that question. Next, please. Let's now talk about early stage cancers, that's stage 1 to stage 3. And let's classify the cancers on the basis of what their receptor statuses are. Breast cancers have 3 receptors, commonly known estrogen receptor or ER, progesterone receptor or PR, and the receptor HER, HER2. HER does not stand for her as a female HER, it's human epidermal receptor HER2. So targeting these receptors on cancer cells helps us to manipulate the cancer in the tumor itself. ER/PR positive, HER2 negative breast cancer consists almost 2/3 of all the cancers. And currently, we decide to give these patients chemotherapy or not on the basis of what is happening in terms of lymph node spread. There is an Oncotype DX test that we use for patients that have ER/PR positive, HER2 negative cancers that are not involving the lymph glands. So many stage 2s and most stage 1s. 10 years or so ago, all of these patients got chemotherapy if their cancers were bigger than 0.5 to 1 centimeter. 2/3 of these patients now do not get chemotherapy because the Oncotype test can divide them into low risk or high risk. But there is also an intermediate risk. And until 2 years ago, we didn't know what to do with intermediate risk, and so we wound up giving them chemotherapy as well. The Taylor-X trial helped us answer that question, and we now know that intermediate risk patients might not always need chemotherapy. Next slide. For women who have a score of 16 to 25, even if they are younger women who are premenopausal, we may not need them to get chemotherapy, but if they have a higher score, then they should get chemotherapy. If they have a lower score, then hormonal therapy alone is sufficient to treat these patients. And so, again, we are able to prevent exposing our patients to chemotherapy related side effects such as low blood counts, fatigue, hair loss, pain, etc. So, Oncotype DX test now should be considered standard of care for patients with ERPR positive, HER2 negative disease if the lymph nodes are not involved. Next slide. What if the HER2 receptor is positive? So now we have triple positive disease, ERPR positive, and HER2 positive. These patients are often treated and seen by medical oncologists before they go in for their surgery because we have the option of shrinking the cancers and being able to see how well we did with treating them in order to determine prognosis. Standard of care involves a combination of chemotherapy drugs and targeted drugs against the HER2 protein. This includes a drug called trastuzumab or Herceptin. Second drug called pertuzumab or Perjeta, around 4 years ago, also started becoming standard of care. The problem was, even though we were treating patients with Herceptin or trastuzumab and pertuzumab prior to their going into surgery, when the surgery was done, patients still had some cancer cells that did not get destroyed or killed by the chemotherapy. Obviously, that translates into the fact that if they're still present in the breast, they may still be present in your circulation and might eventually lead to distant spread in another organ. What do we do with these patients? The Catherine trial answered that question for us. And we now know that if after the time of surgery you still have cancer left behind in your breast, we can switch the drug out and change it to a different drug that improves your prognosis. Next slide, please. That would be, I believe, 23.
I am sorry, I was responding in the text and I don't know what happened here.
I think we can go to 23. I think that's where I left off.
Okay, thank you.
So trastuzumab emtansine, or TDM1, or Kadcyla, all three are the same name, is a drug that is not just trastuzumab, but it also has a small chemotherapy drug linked to it. And this drug was studied against trastuzumab in nearly 1,500 patients, and the patients who got TDM1 appeared to have a 50% lower risk of death than the patients who just got trastuzumab after their surgery if their cancers were still left behind. This is now standard of care and should be considered in all patients with ERPR positive, HER2 positive disease that get neoadjuvant curative therapy. Next, please. Let's now talk about some of the new breakthroughs that we have in stage 4 breast cancer or metastatic breast cancer. And let's continue to break it down according to what the different markers on the cancer cells look like. Next, please. So continuing on, let's talk about HER2 positive breast cancer. This can be ERPR positive or ERPR negative, okay? HER2 in general is an aggressive marker, and until now, we have several drugs that we were able to use: trastuzumab or Herceptin, pertuzumab or Perjeta. Perjeta was a new molecule that was approved by the FDA around 2016. And other drugs such as Kadcyla or TDM1 that we talked about, other tyrosine kinase inhibitors such as lapatinib, which used to be given in combination with chemotherapy or with trastuzumab. A recent trial called the HER2 CLIMB trial looked at patients who had already exhausted most of these anti-HER2 drugs. And it looked at a new drug called tucatinib or Tukitsa, which was given in combination with trastuzumab and an oral chemotherapy agent called capecitabine or Xeloda. Next, please. So patients who were on tucatinib did significantly better than patients who did not get it, even in the group of patients who had already gone through multiple different HER2 options. For the tucatinib combination, the progression-free survival at 1 year was 33% versus 12% in the placebo arm, and the median duration of progression-free survival was 7.8 months. Overall survival was nearly 45% in these patients versus only 26.6% in the patients who did not get the drug. Even in patients who had metastatic cancer to their brain, which is usually considered aggressive disease, progression-free survival was 24.9% in the tucatinib arm. None of the patients in the other arm had progression-free survival. All of those patients' cancer progressed. And so we now have a new drug that we can use after patients have exhausted all of our previously known options, with a still around 25% chance that the cancer will not progress ahead and will stay stable, thus helping us to fight this cancer a little bit better than what we did before. It also makes these patients live longer as per the overall survival data. On top of that, we had another drug that was discovered called Enhertu or trastuzumab deruxtecan, which is another antibody conjugate just like TDM1. In this trial called the Destiny Breast 01 trial, there were 184 patients who were enrolled who had already gone through 6 different options. And these patients were then given trastuzumab. Now, usually in any kind of cancer, the more and more agents that you expose the cancer to, the population of cells that continues to survive and continues to grow are cancer cells that have managed to figure out again and again and again and again how to live through toxic agents that are trying to kill them. So the more drugs that you go through, the more resistant your cancer gets. So we now have 184 patients who had gone through 6 different treatments with significantly drug-resistant disease. These patients were treated with trastuzumab deruxtecan. These patients did again remarkably well on this drug, which proved that this drug does work. The median duration of response was 14.8 months with progression-free survival of 16.4 months. Next slide. That basically tells us that for patients with HER2 positive breast cancer, we can offer patients now 2 additional therapies, hopefully allowing them to go into remission and definitely allowing them to live longer than what we were able to do a year or so ago. This slide talks about patients who have ER/PR positive breast cancer, which is metastatic. These would be HER2 negative patients. So there was a new foci on the genetic structure that we were able to identify called the PI3 kinase and the PIK3CA gene, which controls this enzyme called PI3 kinase. This enzyme controls cell death, and so when there is a mutation in it, that causes the cell to grow without any checks. 40% of breast cancers now are identified as having PI3C kinase gene mutation, and a drug was discovered that targets this particular genetic mutation. The drug is called alpelisib. It is given in combination with an anti-hormonal therapies called fulvestrant in patients who have hormone receptor positive HER2 negative breast cancer. And again, patients did wonderfully well, 20 months versus 11 months. Putting this drug, which is an oral therapy with a once a month injection of fulvestrant, again, at the top of our list of therapies to use for this group of patients. Next slide. PARP inhibitors are also under a good amount of study these days because of their ability to fight mutations in the BRCA1 or BRCA2 gene. These cancers grow because of mutations in these genes that are cell death controlling genes. And when the gene is mutated, again, the cells can grow haphazardly, which causes the cancer growth to progress. PARP inhibitors are a new class of drugs. We are seeing them used against a bunch of different cancers, ovarian cancers, prostate cancers. They're being studied widely for patients who have BRCA1 or BRCA2 positive cancers. 2 new drugs are approved for these patients, olaparib and talazoparib, which are both now, again, 2 drugs that we can use if you have a BRCA mutation in your cancer. Next slide. For patients who did not have any of the hormones that manipulate, any of the receptors, that manipulate their cancer growth, these are triple negative breast cancers. These are more aggressive, often found in patients that are younger. And for triple negative breast cancers, we usually go through various chemotherapy drugs before we exhaust options. A slightly new breakthrough was the use of immunotherapy in these patients, and that was something that got introduced around 2 years ago. Immunotherapy in combination with chemotherapy is used to treat metastatic triple negative breast cancer. However, there was a new drug that was approved that falls in the class of TROP2 inhibitors, which the drug is called sacituzumab govitecan or Trodelvy. Next slide. And triple negative breast cancers, could you go back, please? Triple negative breast cancers do have higher levels of this TROP2, which make them more susceptible to manipulating that gene and helping us to get better control on the cancer cells. The trial that was looked at was something called the ACCENT study. And again, these were patients who were heavily pretreated. In spite of that, nearly 40% of the patients had response to therapy, which is a huge number for these resistant cancers. But this is certainly a new drug in our kitty for treating triple negative disease, and definitely one of the treatments that is going to get wide use by all breast oncologists. Next, please. So knowing that breast cancer exists is not enough. It is our job to make sure that we are educating our friends, our family, our community, reminding your relatives and your sisters and your moms and your daughters to get tested, to get your screening mammograms. If you're 40 years of age, you should go for your screening mammogram. In this day and age of COVID-19, there is a little bit of apprehension about whether you should go and get your mammogram or not. You absolutely should. Centers are now open. They are taking exhaustive precautions to make sure that patients are safe so that they can continue to get screened. If you think something is wrong with your breast health, talk to your primary care doctor. They would be able to send you for a mammogram very easily, and this can give you all the information in the world and help save lives. Next slide. At the end of the day, again, I want to thank you and thank the Center for Women of New York for giving me this opportunity to talk and educate about breast cancer. We are all women, we are all in this fight together, and so please schedule your mammogram today. Thank you so much again.
Do we have Victoria there? Did we lose her?
Sorry. Thank you, Dr. Trivedi. I would like to say in Hindi, Dhanyavad, and in Gujarati, Abhar. On behalf of the Center for the Women of New York, we thank you for sharing your knowledge with us And if you would like to reach Dr. Trivedi, her number is 908-957-9696. And now we have our breast cancer survivor, Argie Moutafis-Agelarakis. Argie is a Greek-American artist working in New York and Greece, and she earned her BFA at the School of Visual Arts, her MA at Adelphi University, and is a part-time faculty member at both universities. In the end, her art helped her get through surviving breast cancer. The breast cancer influenced her work in terms of color, shape, and composition, again, conveying harmony and hope. And I know her art was her therapy as well. And she knows how art as therapy has its history, has its place in our present day society to help us get through crises. And we welcome Argie. Thank you.
Okay, well, thank you for having me on again. I was lucky because I actually took a friend for a mammogram. She felt a lump and was afraid to go to the doctor. So I dragged her butt to my doctor, who felt it was a very large mass, and sent her for a mammogram. And she did have breast cancer in both breasts. But on our way out, she said, you know, you brought your friend, but you haven't been, for a mammogram in many years. I was like, it wasn't many years. It was just a year or two ago. You don't realize how time flies. It was, in fact, about 5 years. So who likes to go for a mammogram? Nobody likes to go. I did go. And because I am very cystic, usually the technician would take me in for a mammogram. I would go back to the room. They would bring me out again. They would take me back, take me for a sonogram. So I was used to the back and forth. This time was different. They did find something. So after the sonogram, the doctor came in and said in a very cold way, you need to get a biopsy. So I was shocked. Before I can even ask, or I think I did ask, I said, well, can I wait? I have classes, I have this, I have that. And he was like, no, it has to be done right away. And he walked out. The technician, though, having had the experience herself, followed me back to the room where I got dressed, sat me down, and told me exactly what to expect from the biopsy. So this is where it really helps to speak to people who have gone through it. I left. I didn't tell anyone. I didn't tell my husband for several days. I didn't tell my son because he was studying for his SATs and, getting ready to go to college. My mother wasn't well at the time. I didn't want to worry her or my dad or my sister. So I really said nothing for several days. Then did tell my husband. We scheduled the biopsy, which was another experience. I spoke to no one. I tried calling my doctor, but she didn't want to have a conversation. I guess she was busy. She's a gynecologist. She felt it's best to speak to the breast surgeon, right, or whoever would take over from there. I was lucky again to find a brilliant breast surgeon and an even better plastic surgeon who took the time, sat down, talked about all the procedures. And at I guess my daughter was the one who forced me into considering a prophylactic mastectomy. So about a year after the lumpectomy, I went for another mammogram. It didn't show anything. But in the back of my mind, I knew there was something. So I told my daughter, and because it runs in my family, both on my father's side and my mother's side, we both decided to have the prophylactic mastectomy. Mine ended up being cancer in both breasts. I have to also go back and say, when I went to the oncologist, she recommended tamoxifen, which is that estrogen receptor right, that the doctor was telling us about. But the side effects to me sounded very scary. And because it was only the first time, I was borderline if it was going to reoccur, I opted out. If I had opted for it, it may not have spread. I don't know. But I did go through with the prophylactic. It took several months to recover because I had the deep flap as well. That's where instead of removing the breast tissue and putting in implants, they remove belly fat and a large slab of your belly. It's basically a tummy tuck in addition, and they use that to fill the breast. My doctor, who was the breast surgeon, recommended test the lymph nodes. She recommended not to do the nipple saving, which was an excellent choice on her behalf because the cancer was back in both. I would have had to have gone back and had that removed and had to go back to test the lymph nodes. There was no need for me to go through chemo, and there was no need for me to go through radiation. Post-surgery was difficult. What I have to say is you need to speak to other people who have been through it, because family, who you do find out when you go through something like this, because it was many months of recovery, psychologically, just as much physically. I found I worried more about the people around me. My husband, my daughter, who was pregnant, actually she just had another baby, my son who was going into college, my husband. I mean, we're women, we know how much we do in our households, right? It's not just our work, it's, the laundry, the cooking, the cleaning, the organizing, making sure everybody is in order and things are under control, even the pets and the birds and everything else. It all kind of depends on us. A lot falls on us. In my family, being Greek American, it was hard to find out family history because it was not something women talked about, especially people that aren't married, right? I did have a cousin who wasn't married, who wanted no one to know about her breast cancer because it would hinder maybe finding a husband. Had we known a lot of the history, maybe we would have taken another approach. I would have gone for that mammogram every year and not waited 5 years. So it's important to share your family history with your family members. It's very important. It's very important to find support from people who have been through it. Because like I said, a family member who hasn't been through it will say, don't worry, everything will be fine. You'll see, but it's not always fine. And you need to speak to people who have been through the entire process, who know what the hospital stay is going to be like, who know what pulling out those drains is like. I didn't know. My daughter and I went and they pulled out these drains I thought were just on the surface, and they were actually coiled in the breast and coiled in the belly. But if you know, you're prepared, you're talking to people. I didn't know many of these support groups existed. Adelphi University does have one. They've been providing community outreach and services for 40 years, and I didn't know about it. And it's only now because I shared this that they said, we've always been here, but I didn't know. So really speak to people. My doctor's office paired me up with people that were going through what I did, that were within my age group, that, were working mothers, had husbands with other women like me. So I knew what to talk about with them. The same with my daughter. They matched her up with younger women who were doing this just prophylactically. She never had it, but because the fear she had of us having it on both sides of the family prompted her to do it as well. So I credit her with saving my life, because if I didn't do it when she did, that yearly mammogram would have come 4 months down the line. I would have needed the chemo and the radiation and everything I went through. So yeah, you need the support, and there's a lot of support out there. Find people to speak to, not just family members, people who have really gone through it. Share your family history with your family. It's very important. You may be saving their lives. This is a picture after the summer after my surgery. You could see I was fine. I was happy. The painting on the right has a story because as I guess a lot of creative people, we get this burst of creativity when we are stressed, like now with COVID, in isolation. It's when we kind of have this burst of creativity. I was painting a lot and I took out my oil paints and my daughter said, you know, mommy, draw me a paint me a fairy. I want to put a fairy in my living room. So I was like, okay, sure. You know, well, I painted her fairy and this was the fairy I painted. So she came and she was quite horrified and she was like, this is not a fairy. It's like, of course it's a fairy. And she said, no, mommy. She said, it looks more like you. And I looked at it and I was like, yeah, the new boobs, the cut on the abdomen, the hair, the feeling free and alive again, the circles, right? If you know about mandalas and the meaning of mandalas and the circle being a universal symbol within cultures, it's all there. I know you're not supposed to analyze your own art, but when I do, it's there. This is my self-portrait for that time. So as much as many times I would like to donate it or sell it, it's there because when I'm feeling a little bit down or a little insecure and isolated now because of COVID, working from home, I can look at that and say, you know what, I went through worse. We're all safe, we're all healthy, life goes on. So get the support. And that's it for me. I hope it helps, inspires others. So any questions, I'm here.
Thank you, Argie. Efkaristo.
You're very welcome.
We really appreciate your sharing your survivor story. It's very important to know the research from very, very knowledgeable doctors, but it's also great to hear the story and the journey. So we really appreciate your opening up your heart to us. And you can contact Argie at her website, www.argiesart.com. That's ARGIESART. Thank you again.
Oh, you're welcome.
Thank you. Thank you, both of you. So that was really, you said, I hope it was inspiring. It was really inspiring. Seems like it gives you a lot of strength to go through something so hard. We really appreciate both your presentations and they're so informative presentation of Dr. Trivedi. Thank you. And now,
can I say something?
Sure.
I had surgery on my foot back in July. And it's only been 3 years, not even, it'll be 3 years in December. And I went to Long Island Jewish and they said, oh, you know, I don't have to go through it. I'll just confirm your history because it was in the system. That's where I had my surgery. And she said, oh, you had cancer. And I was like, no, I didn't. And she looked at me, she goes, yes, you did. I forgot.
Wow.
I forgot. I was like, well, yeah, I had the mastectomy, but it wasn't cancer. And she was like, yes, it was. So life goes on,
Yes.
you know, it does go on. There's hope.
There's hope. Time heals all wounds.
It does. It really does.
We all have to give ourselves time to grieve, to grow, to get over it, and to move on. But it takes time.
Thank you so much. That you know, it gives us a lot of hope. So we really thank you both. And now we can open it up to questions. There were a couple of questions in the chat. I don't know if you had the chance to look at them, but feel free, anyone, to ask questions to any of the two presenters. If you would like me to read the questions, I'm happy to. Just let me know, Dr. Trivedi and Argie, unless you already looked at them.
You can probably read them out too, so that I think everybody knows.
So everyone hears that. That's a good idea.
Good idea.
It says, my question for Dr. Trivedi is like, we know women are diagnosed predominantly with a mammogram. How are men generally diagnosed? Is the prognosis of men equivalent to women?
So men are usually men do not have that higher risk of breast cancer as women do. The risk of breast cancer in men is higher in patients who have a genetic mutation in their family. So again, like Argie said, family history is important. History of breast cancer predominantly through many generations on one side of the family, or history of breast cancer along with history of ovarian cancer should be a red flag. Ovarian cancer and breast cancer either in the same individual on the same side of the family, or in multiple family members, different generations, could be a sign of what we call the hereditary breast and ovarian cancer syndrome. These are patients who can carry the BRCA mutation. If there is a breast mass which is felt, usually the test is still a mammogram. Men do not go for screening mammograms. However, if there is a suspicion of a breast mass, which oftentimes can be picked up on chest x-rays, CAT scans, or just by self-palpation, nipple discharge, or bleeding, even in men, the test is a mammogram. Men are treated in almost the same way as women are treated. Recently, the first guidelines actually for treatment of breast cancer were published in what we call NCCN, which is the National Cancer Treatment Compendium that medical oncologists use. Due to the rarity of breast cancer in men, the amount of patients that we have in clinical trials is much less, and we extrapolate a lot from how women do with their treatments to recommend treatments in men with some tweaks and changes. But prognosis-wise, again, it sort of runs the same, with the little exception of, given that these cancers are found in patients who have a higher chance of a genetic mutation, oftentimes at diagnosis, the cancers are slightly more aggressive.
Thank you, Dr. Trivedi. I think you touched a little bit on this, but there's a question about, should mammograms be yearly? If you have never had a history, now with COVID, some recommend skip the year.
So I personally do not, unless we are in complete lockdown. In the spring, between the months of February or March, rather, actually through June or July, a lot of the imaging centers were closed as well. Right now, I would say almost 100% of them are open. Delaying your mammogram for a few months because of something like this is a different story. Skipping an year could have potentially, different consequences. If you are older than 75 or 80 and you choose to skip years, that's a different story. However, younger women, the risk of skipping an year is the fact that what could have been an early stage and small cancer that could be easily treated, and a year later may wind up being something that requires you to get chemotherapy or more surgery. And that's the reason for not skipping. Most breast cancers cannot be felt. Okay, so remember that even if you're doing a self-breast exam, which is an excellent way to continue to screen yourself if you're not going for one, you still might be missing a good 50% of all the breast tumors.
Thank you. I have a question for Argie. It's so interesting that you forgot, and I know it happened.
I forgot. I mean, I knew I had the mastectomy. I've got this enormous scar on my belly. But when she said, oh, you had breast cancer, it shocked me.
So one of the things that I will always fear is that once the cancer is removed, it's a fear of showing up again. So I guess like recovering gives you so much strength that you can live without that fear. Is that right?
That's exactly it.
Mm-hmm.
That's exactly it. Thinking positively. I mean, I still go to the doctor. I go to the breast surgeon every year. I don't have any more mammograms. I don't have to. I go to my cardiologist every couple of months. I still go. And, I'm healthy otherwise. So, yeah. And like I said, I mean, for me, I was more afraid what was going to happen to everybody else. It's like, okay, you know, I won't be here. It's just, you know, I'm here now. I may not be here tomorrow. You know, I lived a happy life. I'm good. I did a lot. But what's going to happen to everybody else?
Right.
That was my,
And just to close, I think it'd be very important to mention the importance of those support groups, like not just you. But there's another question, so I don't want to skip it, but I also know that we are running out of time. But like you find that you are helping others now, right, Argie? And I'm sure Dr.
Sure.
Trivedi maybe can add something to that too. The people who experienced it help others as well.
And then this is the strength that I was mentioning. On a daily basis, I am amazed how resilient my patients are. And Argie, like you said, I mean, going through this cancer journey, it is certainly very important for women to, seek out help. A lot of times, you're right, even though your mom or your sister or daughter is your best friend, they might not be your best partner going through therapy, because they can sometimes, try to skip the bad news or the hard parts and try to shield you from it. And when we talk to and counsel our patients, sometimes, we hear that where the family members take us outside the room and tell us, please try to soften, whatever you say. And we love to try to do that. However, that may not be, bless you, that may not be the patient's personal wish. And so, I'm glad that, I'm glad that centers like this that provide this kind of outreach and support and help are there for women to turn to when needed.
and it's also easier. I found it was easier to speak to somebody who didn't know me, because I wasn't afraid of like being judged or wimpy. You didn't have to be strong. You could cry. They're not going to look at it. It's very different. It's very, because we try to be strong, for our loved ones, right? We don't want to worry them. We don't want to cry in front of them. We don't want to tell them what we're really feeling. We don't want to hear everything's going to be okay. Don't worry, it's going to be fine. No, I want to hear that, you know what, when they pull these drains out, you're going to scream because it hurts like hell. You want that, and you want to be able to cry or say something stupid and not be judged.
We don't have anything to stop or prevent breast cancer.
Dr. Trivedi,
can
if
only,
I was talking to Argie, if the lymph nodes are removed, you can still take the vaccine and the injections on the same arm?
You can take vaccines, yes. I mean, in terms of injections, I think the problem for lymph node removal is lymphedema, which is interruption of the lymphatic flow. Lymphatic fluid is a clear fluid that is separate from the arterial blood and the venous blood, but also drains out through the arm. Interruption in this lymphatic flow can lead to accumulation of lymph in the arm and cause your arm to swell. And not swelling like you see in your legs at the end of the day, where you put your feet up and the swelling goes down. Lymphatic swelling is harder and oftentimes more permanent. You should try to avoid injections and blood draws and blood pressure checks. Arm
They do it to me all the time. And with many doctors, because I've had to have many endoscopies and everything else every year.
You should avoid, right? That's what I think.
They tell me no.
So if you've had lymph nodes removed, that side you want now, again, for bilateral mastectomy patients, yes, where do you go? I mean, you have an arm. So, I think, it depends upon how many lymph nodes also.
Right.
Sentinel lymph node, which is commonly done, where 1 to 3 lymph nodes are taken out, is not that high risk. Okay, so even though their patients are counseled not to do it, in terms of risk, it's very low. If you had 30 lymph nodes pulled out, or what we call an axillary lymph node dissection, I would personally, as a physician, recommend that you do not get blood pressure on that side.
Wow.
Yeah, thanks so much.
So Malini, it's important to know that there are 2 types of lymph node removals. And that was when I had my surgery back in the year 2000. That was one of my biggest decisions to make. You see, as time goes on and new treatments come about, that was in the early phases of sentinel node dissection, where they inject a radioactive dye and they watch this dye travel to the
Wow.
away from the breast, and those are the nodes that they remove.
Mm. Wow.
So
And
they
we
remove
have a
fewer
full-
nodes, and they analyze them more deeply, those 3 or 4 nodes, whereas with the other dissection, they don't know what they're taking out. So they take, oh, my mother had 16 removed, and many of them had cancer. So, but in her case, it would be very dangerous to have blood pressure taken in that arm. But in my
Okay.
case, they always ask me which arm. I say any arm, you know,
Oh.
because I didn't have all those lymph nodes removed. I only had
Okay.
3 removed. So
Oh, it
all of
depends on
my
the
lymph
amount.
nodes are intact. They're
Right.
not
Oh, wow.
compromised.
Yeah.
But it was a major decision for me
Yeah.
because my biopsy surgeon did not believe in sentinel node dissection, nor did his hospital. And yet other surgeons that I saw after that did follow the studies, and there was 1,000 women study in Florida that one of the consulting physicians told me. So I want to tell the audience, do seek a second opinion.
Okay. Wow.
I had opposing opinions on the type of dissection to figure out if I had metastasis or not. So these are major questions that we have
Yeah.
to answer in this trauma of being
Yes.
diagnosed. But as Argie said, and as the good doctor said,
Yeah, that's what
we
I'm saying.
need
Now
to
we have Dr.
speak to
Trivedi.
people who have gone through it.
Yeah.
And many people referred their family and loved ones to me for counseling. And what I learned in counseling is that not everybody's story is the same. Who was toiling over whether to have a needle biopsy versus a surgical biopsy? That was not my problem. My problem was mastectomy versus lumpectomy. So as we counsel, we have to keep our minds open that their situations are different from ours as well.
And if I may just add, this was what we are trying to do in medical oncology. I can tell you in surgical oncology, these are the constant questions that we still, to a certain degree, are trying to get better at. How to treat our patients by making them go through as little as possible changes with regards to the breast, the lymph nodes, the arms, the lymphedema. And counselors like all of you and our survivors and our fighters who are enrolling in our trials are the ones that are moving this needle forward, are helping us answer these questions. And a very, very grateful thank you to all of those who seek out clinical trials.
Yes.
Absolutely agree with the second opinion. It's your body, it's your cancer. If you are not 100% sure of what you want to do, ask. There's, we're in a region, thankfully, where there's no dearth of good cancer centers, good doctors, and medical institutions that can help.
And different doctors have different opinions, strong opinions on newer treatments. We all interpret studies different ways. So I think a second opinion is very important with all the new therapies coming out. Certain hospitals don't pick up the new therapies, so the doctors affiliated with those hospitals will not recommend them. And again, it's about personal beliefs. My biopsy surgeon felt strongly that I should have a lumpectomy. And I just knew I needed a mastectomy. So when I went to the second surgeon, they said right away, they looked at my at my films. My cancer was not a tumor. It was little dots of, they call them crystallizations in the mammogram. And they followed the pattern of these crystals, of these salt crystals that, see, I need those layman's terms. The doctor would say, you see these, like they look like salt crystals? Well, these, when they're clustered like this and they form patterns, they're an indication of cancer. So a low indication, but still an indication of cancer. So this biopsy surgeon said, if you were my wife, I would say lumpectomy. Why did he say that? Because prior to my year of breast cancer surgery, there were too many mastectomies when lumpectomy should have been done. So he wanted to be conservative for all those women that lost a breast for no reason. So although I totally disagreed with him, I went to another surgeon, and then I had to go to a third surgeon because I had two opposing opinions. I can't make that decision now. When the third surgeon said mastectomy, that's when I decided. But what really helped me decide, Argie, my best friend from childhood was a radiology nurse. She said, have a mastectomy, have them both removed.
That's right.
She said, I have seen women come back with the one breast or the lumpectomy. She said, you don't want to go back.
Right.
And that's what told me. So after my surgery, I felt light as a feather.
Yes,
I felt all my
exactly.
cancer was gone.
It's done.
I felt like I made the right decision because I had seen so many surgeons. But the problem is, for those of you on the call, it's not everyone's patient style to see so many physicians and to have so much information. If one is enough for you and you feel confident and you feel that connection, then that's your decision. It's all about your personal patient style. If you don't want to be overwhelmed with too much information, then don't do what I did. I was in a state of confusion with all these opposing information. Mastectomy versus lumpectomy, sentinel node versus ancillary node. I mean, and the list goes on with all the decisions I had to make. So, but that's my style. I don't want to regret. I want to know everything and make it my problem that I knew everything and that was my decision. Not to be angry that someone forgot to tell me something.
Thank you, Victoria. And so I think it's really valuable that you share your story as well.
Thank you.
On behalf of all the center, we thank our president for sharing her personal stories. Thanks, Dr. Trivedi.
Thanks.
Thank you
for sharing your knowledge, and Argie for sharing her survivor story. We really appreciate it. And I love to stay talking. I also want to be mindful of everyone's time. We'll send a follow-up email asking you how it went and for feedback. We always want to make these educational webinars better. I think it was amazing. So thank you. Again, if you would like to volunteer, you can go on our website. It's CWNY.org. I won't bore you with all the slash and all the words, but you can find everything on our website. It's CWNY.org. These slides again will be on our website as of tomorrow, right, Victoria?
Right.
And again, we have, I already mentioned, and I think everyone stayed, so I won't repeat myself, but please reach out if you need anything, and if you're interested either in what we are offering now, or if you have any ideas, any suggestions in terms of like services or programs that we can offer, please reach out to. We always need new, fresh ideas. Just a reminder, on November 10th, we have our workshop conversation, the power of financial independence, COVID and beyond. Thank you so much for coming, for showing up to this webinar. If you go, I know no one will memorize this, but we have resources here for breast cancer helplines. Please go to our slides as of tomorrow again and find the resources that will be very helpful for anyone going through this journey. There's more, and you can visit us on any social media. We're always trying to keep you up to date in terms of what's going on at the center. We're on Facebook, Instagram, and Twitter. And we have our YouTube channel with the webinars. Our email is info@cwny.org, and our phone number is 718-793-0672 or 718-229-0020. All right, thank you. Thank you. You have a great rest of your day.
If I can share something, especially to Dr. Trivedi, This
Good.
scarf that I'm wearing was given to me by my breast surgeon's wife.
Uh-huh.
She worked in his office and we connected. And I will always remember my surgeon and his wife because of this scarf.
Mhm.
They are the reason I'm alive. So,
Such a lovely.
Doctor, we do appreciate all you do. Right, Argie?
Oh my God, for sure. Oh
Because
my
God
yes.
is in the surgeon's hands.
There are heroes,
Yeah.
real heroes, especially in times like like today.
Yeah,
Real
so
heroes.
thank you. Thank you for sharing and taking this time out of your busy schedule, Doctor.
Absolutely. It was my
Thank you.
pleasure. Thank you all.
We'll be
Bye,
in
all.
touch.
Bye.